Today is a fantastic topic, is polycystic ovary syndrome, brain phenotype, and fertility management. And we will have two speakers on the two different chapters, very well differentiated one from the other, but who are part of all the problems that a PCO suffered during her life. The first topic is the brain phenotype in polycystic ovary syndrome, androgens, anovulation, and gender, and the speaker will be Professor Sara Berga. The second one is fertility management, and the speaker is Professor Basil Tarlatzis from Thessaloniki. Professor Sara Berga, she currently serves as professor and chair of obstetrics and gynecology at Jeffcoat School of Medicine and Biomedical Science in University of Buffalo, New York, and medical director of Women Health Program Development for Kaleida Health. Her research explores neuroendocrine mechanisms regulating gene age drive in women with polycystic ovary syndrome and functional hypothalamic amenorrhea, and hormonal contribution to brain health, utilizing neuroimaging combined with characterization of hormonal and cognitive patterns. She currently serves on the board of the International Society of Gynecological Endocrinology and the board of trustees of Salem Academy and College, the first women's college in America founded in 1772. Sara, you have the microphone. Thank you.
Thank you, Professor Genazzoni. Always a pleasure to join you and to join ISGE and Professor Tarlatzis. This is a great honor, and I would love to talk a bit here today about the brain phenotype in PCOS, androgens, anovulation, and gender. So without much more ado, here are my conflicts of interest and consulting. And then what I would like to talk about today is, are the brains of women with PCOS partially androgenized? And how do we put into perspective the recent information about the genetics of PCOS and what does that tell us is going on? So as you may know, recently we have kind of, I would say, thought some more about the paradox of PCOS, which I like to articulate as too many eggs get chronic anovulation. So it seems paradoxical that you could have so many eggs and yet not ovulate. But we know that this is due to insufficient FSH, so that there is not sustained folliculogenesis. And now we know that there are lots of eggs. We can both measure them by ultrasound and also by measuring AMH. And we also know that when we give little tiny amounts of FSH, we get amazing ovarian responses. So the eggs are actually responsive. It's not actually resistance to FSH. And we've wondered why this is for a long time. So, the operating hypothesis for the last 40 years has been that LH is too high, and that this leads to theca cell stimulation and increased androgen secretion, and that the FSH is too low, and so the granulosa cells and the follicles are insufficiently stimulated. And there were lots of amazing data in the 90s looking at LH pulse patterns. I'm showing a few of those here. And we figured out during that time that testosterone regulated the GnRH pulse generator. So it all started to make some sense in terms of pathophysiology. And we could also show, and we and others have shown, that the GnRH drive, if you will, the hypothalamic GnRH pulse generator, is actually relatively resistant to steroid feedback. So here we're showing a paper of ours showing that women given oral contraceptives actually for 3 weeks do not suppress to the same extent as do eumenoric women. And we and others have tried to figure out why that is. And it does appear that androgens more than insulin plays a role in creating this feedback resistance. So what is the primary androgen that the ovary makes? Actually, it's androstenedione, and this can get converted to estradiol if there's aromatase around from the granulosa cells, but if not, a lot of it gets converted to testosterone, hence the problem. This is an absolutely wonderful diagram from a review article in the New England Journal of Medicine. And you can see here that generic pulse generator is shown. It took us a while to integrate this idea into the pathophysiology of PCOS. But now we really know that there is a brain phenotype. And so I think initially people thought this was primarily an ovarian problem and that the brain was sort of innocent, if you will, hostage to the rest of the story. But it may be that the brain is much more fundamental in understanding the pathophysiology than initially conceptualized. So, thinking about the cardinal features of PCOS, we all know that one of the cardinal features is chronic anovulation, polycystic ovaries, which typically get misconstrued by everyone as a problem with the ovary. But the eggs are there, and maybe there is an excess of eggs, an increase in eggs. And for every egg, there is a layer of theca cells, so hyperthecosis. And the question is this really an ovarian problem, or is it a little bit more complicated than that? We also know that hyperandrogenism is not always phenotypically evident and really depends on ethnicity for expression. But it does appear that underlying almost all cases of PCOS is in what we would call gonadotropin aberration, with a rapid GnRH-LH pulse frequency, insufficient FSH, and an increased LH-FSH ratio. This does lead to a disordered endometrial development, and many, many times there is associated insulin resistance and metabolic syndrome, and often an android habitus with truncal obesity. So these are some recent ultrasound pictures from my office, just showing stromal hyperechogenicity in the bottom panel and just the classic pearl necklace here of follicles just in abundance. So our criteria for PCOS are many. Many organizations have weighed in on this. I'm showing just a few. All require exclusion of other causes. None require exclusion of stress-induced obesity, and none require insulin resistance or screening for diabetes and cardiovascular risk factors. So recently, the American Association of Clinical Endocrinologists has come out with some guidance around this to suggest that patients with PCOS, particularly those who are undergoing infertility therapy, be screened for diabetes and cardiovascular risk factors. This is not news to any of us in the field, but it is news to some diabetologists. So we've tried to really make sure that people not only rule in polycystic ovary syndrome, but also rule out other causes. And so I've just made this list somewhat provocatively to get people to think about the differential diagnosis before rendering the diagnosis of PCOS, because many of the patients I see actually don't have PCOS at all and have some form of stress-induced obesity, overeating, emotional eating, you might say, and really a form of obesity, hypothalamic amenorrhea syndrome. So either PCOS has multiple etiologies, and we've really struggled with this as a concept, or the pathogenetic explanation must account for all the cardinal features that we've just reviewed. And this wonderful study done in part through the University of Utah, which has an amazing genetics program, and the some of the larger databases in the United States and in the world, including Ancestry.com, were utilized to do this large-scale genome-wide meta-analysis of PCOS and suggested that there was a shared genetic architecture. But what was interesting is there wasn't one gene. And so previously people had sort of hypothesized there was one or a few genes. 14 variants were found in this large-scale genome-wide meta-analysis. 3 were new, and 11 had been previously described. And some of the variants were associated with hyperandrogenism and gonadotropin regulation. So that's actually helpful. And some are actually showing a shared genetic architecture between metabolic traits and PCOS. But what was interesting with 14 variants, then you have to think about subtypes of PCOS, because not every kind of PCOS is going now to look the same. And this is just a Manhattan plot showing the meta-analysis, adjusting for age, and some of the genes that were identified. And we're still working out what these genes actually do. So where I think we rest at the moment is starting to appreciate that PCOS is a complex polygenetic disorder with a spectrum of presentation, not a unidimensional, unigenetic condition. There's also obviously a gene time environment interaction, and this leads to a complexity of clinical presentations, and we have to say no single phenotype. So even though this is a spectrum disorder, we still want to ask some questions about what is actually shared. And so question that we've been asking in our laboratory is whether or not reproductive and metabolic features of PCOS might be due in part to altered central GABAergic activity. So this is just a little diagram of our hypotheses that we are exploring. And so we are wanting to look at GABA as a regulator of GnRH and LH pulse frequency, which we feel we have established as the approximate cause of the chronic anovulation. And here you can see that we're wondering if GABA is regulated by insulin resistance or androgens or potentially both. So over the last 20 years, Ursula Kaiser, who's now the president of the Endocrine Society, has been working on really the anatomic, what one might say, the anatomic network that regulates GnRH. And it's gotten to be a lot more complicated than we initially thought. So, of course, everyone initially thought that all the regulation was at the level of the cell body or down at the median eminence, where you have the porous vascular bed that regulates the pituitary. But indeed, this regulation is much more complex than just GnRH itself. And GABA really stands at the top of this really amazing cascade where metabolic cues and reproductive hormones regulate GABA, which then regulates a variety of other neuron types, including candy neurons, and the candy neurons then regulate GnRH at the level of the median eminence and the portal vasculature. So this gives us a vast array of options for thinking about the regulation of GnRH and also the roles of androgens, insulin, and AMH. And this was a lovely study done just a short time ago in 2019, looking at a sheep model for PCOS, showing that androgens, in fact, increase the GABAergic input to the candy neurons and actually led to hormonal feedback resistance. So if you think earlier to the slide that I showed, this all hangs together quite nicely. And then more recently, a lovely study done through Provot's group in Paris, looking at the role of AMH as a regulator of GnRH, showing that AMH could directly act on GnRH or indirectly act on GnRH to increase GnRH and LH pulsatility. So think women with PCOS have too many eggs and increased AMH, and now that might in part also explain why they have an increase in GnRH drive. So a mini review was done by Campbell's group, and you can see here that she also believes that what we showed earlier, and I didn't show the data, is that steroid hormone resistance, feedback resistance, and particularly progestin feedback resistance might be to androgen receptor actually blocking the expression of the PR gene and tweaking this neuronal cascade that I've just described. And for those of you who are interested, this is a lovely summary statement. I'm not going to read right now, but it's really a lovely paper. Our own contribution to this area was to measure CSF levels in women with PCOS who met the standard criteria and all other causes excluded, and to look at GABA levels, testosterone levels, and estradiol levels in the CSF of women with PCOS as compared to women with eumenorrhea. And just to briefly go through this, the PCOS women have higher GABA levels, higher estradiol levels, and higher testosterone levels. And this was published in Human Reproduction recently. And just to put this in perspective with men, so women with PCOS actually have higher, slightly, estradiol levels than either men or eumenoric women. And of course, they're intermediate for testosterone levels between women and men. So that led us to think a lot more, not only about the pathogenesis and how various and sundry signal systems might interact with GABA, but also to think a little bit more about why women with PCOS are chronically anovulatory. And so we think that AMH not only increases GnRH drive and suppresses FSH, but it also makes it hard for patients with high AMH to respond sufficiently to letrozole and clomiphene citrate. And it may be because there's altered feedback sensitivity, so that these drugs are not working in exactly the way that we want them to because there's feedback resistance. And we also know that stress can also play a role and masquerade as PCOS. And in that case, the absence of response to clomiphene citrate and letrozole is due actually to a totally different problem, which is insufficient GnRH drive. So at the end of the day, it really matters to establish the diagnosis from a neuroendocrine point of view and to try to think about what to do, but also to understand really where the patient is in terms of egg number and AMH level, because there are studies showing that the higher the AMH, the less likely patients are to ovulate in response to either clomiphene or letrozole. So that having been sort of a brief introduction to the neuroendocrinology of PCOS and the brain phenotype of PCOS, I'd really like to discuss gender identity and sexual orientation issues. So we've briefly talked about why they're anovulatory, few words about infertility, which Dr. Tarlatzis will expand, a little bit about the metabolism. I haven't really talked about the depression, gender identity, and sexual orientation issues. But we do know that sex steroids play a very big role in brain differentiation and subserve some of the gender diversity that we may be seeing in PCOS. So this topic gained traction in the United States, and I think now worldwide, because people are trying to understand what accounts for the gender diversity in the world. And in fact, we have been asking, is there gender diversity in PCOS that's unaccounted for? And we go back to core concepts. And this is a slide by Larry Cahill from 2005. And this is dealing with a binary universe here. So we're just archetyping males versus females. But what you can see is the brain is clearly imprinted by sex steroids in fetal life. And males and females have different brains and at the level of anatomy and structure and function. I'm not going to go through all of these core concepts, but enough to say that the brain is a target of sex steroids. And, paradoxically, this is mostly through the action of estradiol, which, if you think back, is much higher in women with PCOS at the level of the CNS per our CSF studies. And estradiol alters neuronal cell proliferation, synaptogenesis, dendritic branching, and a variety of other functions inside the brain that sculpt the architecture of the brain and determine its functionality. So now we have to think of gender as more of a mosaic or also a spectrum as opposed to just purely being binary. And so that's what's shown here in this nice review by Art Arnold and Peg McCarthy. So are there any data? Well, just a little. So I think this is an area that's gaining traction, that people are getting interested in, that is sometimes very threatening to talk about. And so there aren't a lot of data, but some of the data are shown here. So this is data related to psychological gender. And this is a study done in 2012 in Scandinavia, and showing that women with PCOS were less likely to identify with the traditional female gender scheme and thought of themselves as androgynous, were less likely to be gender conforming, and were more often likely to endorse a bisexual orientation. And also using this Swedish registry, women with PCOS were found to be at increased risk for bulimia, schizophrenia, bipolar disorder, depression, and anxiety disorders, personality disorders, and autism spectrum disorders. So there's a lot of work that needs to get done that actually hasn't been done, but I think we can now legitimately pose the question, what are these altered sex steroid levels doing to the brain of women with PCOS? So it's not just anovulation, it's more. And so this is just another study from 2004, again, showing that women with PCOS were more likely to express or endorse lesbian behavior and orientation, and that in female to male transsexuals also displayed high rates of PCOS and CAH, congenital adrenal hyperplasia of the non-classical type. This is actually looking at women with CAH and showing that they too had high rates of bisexuality and homosexual orientation. This has been reported for many years, but periodically people have said, well, it's not really true. And so I think, now that we understand how sex steroids imprint the brain, it's time to go back and really ask harder questions and help clarify this area for people. So that was a very high-level, short summary of the brain phenotype in PCOS. And just to say that it's a complex polygenic disorder, so you wouldn't expect it to be binary in any way, because you're not going to have a binary clinical presentation, you're not going to have a binary brain phenotype, and that androgenization may well correlate with AMH. The reproductive consequences are many. And so as physicians and care providers, we need to actually personalize the medical care of PCOS women, not only for their infertility, but to actually help them with gender diversity issues so that they have both better fertility, better pregnancy outcomes, and better family and social lives. So I thank you for your attention. And here are my collaborators over many years that I'm really happy to be part of this team.
Thank you very much, Sarah, for a beautiful lecture. And I have already in my brain a lot of questions. Then we will go now to the second presentation. I remind to everybody, please write your question in the question and answer, and we will put the question later on to our speakers. Our next speaker is Professor Basil Tarlatzis. He will speak about fertility management in polycystic ovary syndrome. Professor Basil Tarlatzis is a professor emeritus of obstetrics and gynecology and human reproduction at the School of Medicine of Aristotle University in Thessaloniki, Greece. He is the current president of the European Board and College of Obstetrics and Gynecology. In addition, he is the past chairman of the European Society of Human Reproduction and Embryology and a past president of the International Federation of Fertility Societies. He also held the position of deputy chairman of the National Authority of Medical Assisted Reproduction in Greece and member of the board of the International Society of Gynecological Endocrinology. Dear Basil, you have the microphone. Please, can you share your screen with us and can you make your presentation? Thank you very much.
Thank you very much, Andrea, for this very generous introduction. It's a great pleasure, as always, to participate in the activities of the International Society of Gynecological Endocrinology, which addresses all kinds of different issues of reproduction, both in females and in males. And actually, I think it's appropriate to remind people that in May, we have our next Congress, the first in-person Congress after 2 years or 3 years. And I think there's a lot of exciting issues there to be discussed. So today I will discuss with you the fertility management. And these are my disclosures, but none is related to the lecture of today. It all started, in a sense, from the ESHRE ASRM consensus meetings. The first one was in Rotterdam, where we discussed the criteria, the Rotterdam criteria that Sarah presented you before. And the second was hosted in my home city, Thessaloniki, to discuss infertility treatment in women with PCOS. And the outcome of our deliberations were published in Human Reproduction and Infertility Sterility. And at that time, it presented what was the evidence concerning infertility treatment. And that's what you can see here is the seafront of Thessaloniki. Subsequently, and pretty recently, there was an international consortium working on the to prepare recommendations, international evidence-based guidance for the assessment and management, which is what we are interested here today, of polycystic ovary syndrome, that again were published in Fertility, Sterility, and Human Reproduction very recently. So when we talk about management, what are the different interventions? The first one that has been discussed a lot is lifestyle changes, and this includes diet and exercise. There have been several studies, and these were examined in a meta-analysis relatively recently by Best and colleagues in 2017, published in Human Reproduction Update. And as we can see here, just the diet and exercise versus control significantly increased ovulation rate. Also the randomized studies with drugs versus control, again, significant increase, but only 2 studies in very small numbers. And then non-randomized studies with diet and exercise versus control, and again, significant improvement of ovulation. But as I said, the number of cases included is rather small. Then we look at natural conception, and again, we have randomized studies, diet and exercise versus control was associated with significantly, or borderline significantly higher natural conception rate, whereas in the non-randomized studies, and here again, not impressive numbers, there was a significant increase of natural conceptions. Now, if we look at lifestyle interventions versus control, the pregnancy rates, as you can see here, there was practically a small but significantly significant increase in the group receiving diet and exercise as compared to control in the randomized trials. As we can see here, the risk ratio is 1.59, and it is significant because it does not cross the unity line. The randomized studies examining diet alone versus control, no difference, small numbers. Randomized studies examining orlistat versus control, significant improvement with orlistat. And then non-randomized trials, diet and exercise versus control, again, significant increase, but not big numbers. And non-randomized norethistron and control, and there's no difference, as you can see here. Lifestyle interventions versus control, as we can see here. In the randomized trials, diet and exercise versus control, not significant difference. Randomized diet and control, no significant difference. Non-randomized, only 1 study or so, we can see that there was a significant improvement. And non-randomized studies, again, no significant difference. And if we look at IVF conceptions, so if IVF is preceded by lifestyle changes, then we can see that there was no significant difference. Actually, there was no difference, as you can see here. There was only a borderline decrease, but not significant, so in the non-randomized studies. So the recommendation from the international guidelines that I mentioned before is that healthy lifestyle behaviors, which encompass healthy eating and regular physical exercise, even though the data are not showing an impressive improvement in terms of pregnancy rate should be part of our advice, because it's part of preparing the woman's body for pregnancy. So as part of health care, we should recommend women to try to do. We all know, of course, that for many women this is very difficult or impossible, but nevertheless, I think it is important to strongly advise that, because that would be good for the upcoming pregnancy. Now, if we go to pharmaceutical interventions, we had historically 2 medications. The first one to be used was clomiphene, and more recently the aromatase inhibitors, and namely letrozole. So there has been a very recent individual participant data meta-analysis by Wang and colleagues, big group as you can see here, and they examined, based on the best available evidence, the live birth rate comparing letrozole with clomiphene citrate, and as we can see here, there is a significant increase in live birth rate with a risk ratio of 1.43, which is, as you can see, statistically significant, and similarly a statistically significant increase in clinical pregnancy rate, again with 1.45 risk ratio. Both, as shown here, are statistically significant differences favoring letrozole. However, we all know that there are 2 specific groups identified within PCOS women treated with clomiphene. There are women who fail to ovulate despite the increasing dosages of clomiphene in 2-3 successive cycles. And those women are classified as clomiphene resistant, and they are approximately 20 to 30% of all women treated, PCOS women treated. A second group is the so-called clomiphene failure, and that's women who respond to clomiphene and ovulate, but fail to conceive after 6 to 12 cycles of treatment, and this is about 60%. So the question is whether we could help those women with the use of metformin. And in the same meta-analysis by Wang, this was examined. So live birth rate, clomiphene plus metformin versus clomiphene alone. And as we can see here, there is no significant difference between the 2. Concerning clinical pregnancy rate, there is a borderline significance, as you can see, but not a big increase in the risk ratio, 1.18. But since it touches the unity line, it's not statistically significant. So the positive effects of metformin on clinical pregnancy rates seem to be more prominent in obese and clomiphene-resistant women. And now we come to see this meta-analysis from the same study, looking at all outcomes. So in letrozole versus clomiphene citrate, live birth statistically high, significantly higher, clinical pregnancy the same, multiple pregnancy seems to be higher, but it is not statistically significant, very low certainty of evidence. Miscarriage, again, no significant difference, and the quality of evidence low, and ovulation rate increase with letrozole 1.13, statistically significant, moderate certainty of evidence. If we look at the comparison between clomiphene citrate plus metformin versus clomiphene alone, so no difference in live birth, as we have shown, borderline significance, but low quality, low certainty of evidence for clinical pregnancy. Multiple pregnancy, no difference, again, low quality, all of them. Miscarriage, no effect, and ovulation, again, no effect. So as we can see, based on concerning clomiphene, low quality of evidence, And in letrozole, mostly moderate quality of evidence. There seems to be that letrozole is more efficacious than clomiphene citrate. And another interesting parameter is the time to pregnancy. And as we can see, letrozole versus clomiphene, that time to pregnancy is shorter using letrozole. And also there is a slight improvement of time to pregnancy using clomiphene plasmidformin as compared only to clomiphene. So the guideline recommendation is that letrozole should be considered first-line pharmacological treatment for ovulation induction in women with PCOS, with anovulatory infertility and no other infertility factor. However, it has to be noted that the use of letrozole for ovulation induction is an off-label use, and therefore in certain parts of the world, this is not allowed. In that case, obviously, clomiphene would be the best alternative option. Now, the other pharmacological agent used historically has been gonadotropins. And initially, when we didn't know, of course, so much, and we were not so fully aware about the complications, it was the step-up protocol. We started at that time, as I recall, with about 150 IUs of FSH, and then if the patient did not respond in 2-3 days, then we would go up to 225 and so on and so forth, and that ended up with a very high incidence of ovarian hyperstimulation syndrome and multiple gestations. Then came the low-dose step-up protocol that were pioneered by our British colleagues, Steve Franks and others. And there are different variations of that. One is the chronic low dose, so to continue with low 75 or even 50 IUs per day for 2 weeks. And then if there is no response, increase by half a dose, so 37.5. And persist there until reaching the threshold, and then dominant follicle is selected. And finally, there was another proposal by the group of Bart Fauser, who tried to mimic what happens in nature. So the initial dose was a bit higher than the low dose used in the low dose protocol. But as soon as the leading follicle or the dominant follicle was identified, then they would halve the dose, the initial dose, as it happens, in the natural cycle when FSH drops, in order to not support the secondary follicles from growing. So that was a step up, step down. So this is a combination. However, today, the most widely used protocols are the low-dose step-up protocols. Now, if we look in a FSH ovarian ovulation induction in clomiphene-resistant, clomiphene failures, these are the cumulative outcome rates. 500 cycles from Bart Fauser's group, we can see that the ovulation obtained is 82%. The ongoing pregnancy rate, 58%, singleton live birth, 43%, and the multiple live birth, 5%, including twins mostly, but also triplets and quadruplets. So this, of course, would include inside the step up and then step down protocol that was used at that time in Rotterdam, which was shown to be associated with a few more multiples as compared to the chronic step up, low dose step up protocol. Roy Homburg and his colleagues have explored whether using as a first-line treatment clomiphene citrate is justified as compared to recombinant FSH as a first-line treatment. So patients were randomized either to receive clomiphene citrate for three cycles or rec FSH. And as we can see here, with a good number of cycles per arm, that the number of pregnancies was significantly higher in the FSH group as compared to clomiphene citrate. The miscarriage rate was not different. Multiple pregnancies, a few more with FSH, as one would expect. The pregnancies per cycle, again, significantly higher with FSH, 26 versus 16, and live births, again, significantly higher, 56, as 49% versus 36%. So based on all the data I showed you, gonadotropins could be used as a second-line pharmacological agent, but they could also be considered, based on the data I showed you, as a first-line, provided that cost is taken into account. So in systems where gonadotropins are offered free of charge from the insurance system, then of course this is not an issue. Patients are available to be monitored more closely with ultrasonography and possible hormone measurements in order to detect early the risk of OHSS and or multiple ovulation and multiple gestation. So gonadotropins could be the first-line option, provided that all these variables are being taken into account. The next one is laparoscopic ovarian surgery, and this is the meta-analysis by Cindy Farquhar's group. And as we can see, they compared ovarian surgery versus for ovulation induction in anovulatory women, and there was no difference. However, we have to mention here that in some of those studies, women who failed to ovulate after ovarian surgery were subsequently given clomiphene citrate or gonadotropin. So it's not a pure comparison of laparoscopic ovarian surgery only versus gonadotropins, but it may be more mixed groups. There was clearly a significant decrease in the incidence of multiples, as we can see here. And there was an interesting study published in Iranian journal some years back, examining live birth rate of pure LOD versus gonadotropins. And as we can see here, there was a significant reduction of live birth rate with LOD only, because this includes women that did not respond with ovulation after laparoscopic ovarian drilling or surgery, whereas in the first slide I showed you and I explained you, some of these women received subsequently clomiphene and or gonadotropins. So laparoscopic ovarian surgery could be a second-line treatment for women who are clomiphene resistant with anovulatory infertility. And of course, it could be offered in women who would undergo laparoscopy for other reasons as well, because we shouldn't forget that laparoscopy is an invasive procedure done under general anesthesia. And also, those who decide to do that should not be aggressive with the electrocautery or the laser, because the more holes we make, the more likely that we destroy some of the stroma and we lose follicles there. Finally, in vitro fertilization as part of ART procedures, there was a big study a meta-analysis which remains classic, I think, from Bart Fauser's group, examining and comparing PCOS women undergoing IVF versus non-PCOS women controls. And so PCOS women had significantly higher cancellation rate. At that time, it was mostly done because of the imminent risk for OHSS. Significantly more oocytes retrieved, as expected, and Professor Berga showed that the follicles are there and the oocytes are there. Significantly more days of stimulation required. Similar fertilization rates, contrary to the general idea that in PCOS women, fertilization rates are lower, and also the miscarriage is higher and pregnancy rate is lower. This was not found in the meta-analysis. No difference in fertilization rates, miscarriage rates, pregnancy and live birth rates per cycle between PCOS women and non-PCOS women. Now, metformin treatment before or during ovarian stimulation for IVF-ICSI in PCOS women, there is no evidence that metformin given before or during ART improves live birth or clinical pregnancy rates. However, an interesting finding is that the risk of OHSS in women with PCOS was significantly reduced in metformin, and that was observed in women treated with a long GnRH agonist protocol. And as we can see here, the pull-joint ratio was 0.27, and that was highly significant. As we can see here, the use of the agonist is associated with a high incidence of OHSS, whereas the use of the antagonist, just using the antagonist, reduces significantly, as we can see here, reduces significantly the incidence of moderate and severe OHSS. The other option, of course, is to segment the cycle, which means to separate ovarian stimulation and oocyte pickup from embryo transfer. That's something that was proposed by George Griesinger and Paul de Vrooy some years back. And the question, of course, came whether the pregnancy rates after freeze-all and subsequent frozen thawed embryo transfer was as good as in the cases where the embryo transfer was done fresh. This was examined by Rock and colleagues, where he put all studies together. And as we can see, in terms of live birth, there was a small but significant increase in the risk ratio, 1.12, whereas in the cumulative live birth, there was absolutely no difference between frozen thawed embryo transfer and fresh. Concerning the incidence of moderate and severe OHSS was significantly reduced in the freeze-all protocols. Our group also did another meta-analysis where we thought to separate the studies which were done in women with PCOS and high responders from those that were done in normal responding women. And as we can see here, in high responders, at that time there were 3 studies available. We could see that the freeze-all and subsequent frozen thawed embryo transfer was associated with significantly higher incidence of live birth, with a relative risk of 1.18. And the OHSS incidence was very significantly decreased, as we can see here in the group of freeze-all. When we looked at the normal responders, and again 1,600 patients, we could see that there was no difference between fresh and frozen thawed embryo transfer after a freeze-all policy, and the incidence of OHSS was reduced again significantly so as compared to fresh embryo transfer. Subsequent to our meta-analysis, there was a study again done in China, where these were normal ovulatory women, and there were a fair number, 825 in each arm. So the live birth and single embryo transfer. So the live birth was in the frozen thawed embryo transfer was 50% as compared to 40%, with a relative risk of 1.26, and that was statistically significant, whereas the incidence of OHSS was significantly was reduced. Now, another study that was published recently from Stormlund in BMJ, again, they put together normal and high responders, and they examined ongoing pregnancy rate and live birth. So if you put all together, there was no difference between freeze-all and FET versus fresh, as we can see here, no significant difference, neither on ongoing nor on live birth rate. And however, there was a difference in the perinatal outcomes, interestingly so, that in women who underwent freeze-all and frozen thawed embryo transfer, there were no preterm births. There were significantly, of course, less than in the fresh embryo transfer, but the birth weight was significantly higher, as we can see here, after FET as compared to fresh embryo transfer. And another one by Way in the Lancet, and then another one by Yu in RBM Online, again recently. They also examined when progesterone was elevated. You know that progesterone elevation in late follicular phase is associated with lower pregnancy rate. So again, they examine, and as you can see, this finding seems to be consistent, because even using a lower cutoff point, 1.14, usually it's 1.5 that we use, still those with elevated progesterone, there was a higher difference between FET and fresh, which was statistically significant, as highly significant, as you can see here. And but in the those with normal progesterone, there was still a difference, which was significant, but not to the extent that was observed in the high progesterone. So another Cochrane database meta-analysis in 2021 examining cumulative results. So it says that there was little or no difference in the cumulative live birth, as I showed you also in the different studies. And there was also a little difference or no difference in the ongoing cumulative pregnancy rate. So cumulatively, there doesn't seem to be a difference. Whereas for OHSS, consistently, it was significantly lower with freeze-all strategies. Finally, there was a big retrospective analysis of the ASRM data, the SART data, 83,000 cycles, as you can see here, and they divided patients into according to the number of oocytes retrieved, 1 to 5 low responders, 6 to 14 intermediate responders, normal responders, and over 15 the high responders. And as you can see, the results are quite interesting. In low responders, there was significantly lower pregnancy rate after FET. Intermediate responders, it was lower, but to a lesser extent, and high responders were significantly higher after FET. And the same trend was also observed in live birth rate. Again, we have to say that, as I said before, that the use of the antagonist per se is associated with lower rate of OHSS. Oops. And then I have to come to my conclusions. So lifestyle modification should be advised in obese PCOS women before ovulation induction, although it is still not clear if this increases the cumulative pregnancy live birth rates. Letrozole or clomiphene are the treatment of first choice, and letrozole seems to be more effective than clomiphene in infertile and ovulatory women with PCOS, especially in the obese subgroup. But we should always remember that letrozole is an off-label use. Metformin alone is less effective than clomiphene in inducing ovulation in women with PCOS. The addition of metformin to clomiphene may increase clinical pregnancy rate and decrease time to pregnancy, especially in obese and clomiphene-resistant women. Gonadotropins in low dose aiming at monofollicular development represent an effective treatment option. laparoscopic ovarian drilling is as effective as clomiphene and gonadotropins for ovulation induction, but probably with less multiples. IVF is a reasonable option because the number of multiple pregnancies can be minimized by single embryo transfer. PCOS patients seem to have similar chances to achieve a pregnancy after IVF compared to non-PCOS. The use of metformin reduces OHSS in women treated by the long GnRH agonist protocol. The incidence of OHSS is significantly lower in the antagonist protocol, and GnRH agonist triggering in an antagonist protocol associated with freeze all embryos and subsequent FET maintains high pregnancy rates, almost eliminating the risk of OHSS. And I would like to thank my colleagues and collaborators in the University of Thessaloniki for doing most of the work I was able to present to you today. Thanks very much, and I'm ready for your questions.
Thank you, Basil. And then we will go now to our, can you close your screen sharing? Then we will go to the question. We have received a huge number of questions, and I would like to start, Sarah, with one of our friend and member also of the board, Fred Naftolin, have raised a huge series of questions. I will mention you some of them. Then he tell you that one. You describe it many facets of the relationship of central axis to polycystic ovaries. Which are the causes and which are the effects is the question. But at the meantime, he asks that visceral fat is the critical element in lifestyle. Do lifestyle changes and metformin have the same effect on VAT on visceral fat in polycystic ovary as in normal women? Sarah, are you here with us?
She's muted.
I am here. Sorry, I was muted. Basil was right.
Okay. Have you followed this question from Fred?
I saw one of the questions. Well, I saw some of the questions, but and they're amazing questions from Dr. Naftolin, of course, who really knows this area as well as anybody. And it is true that there's a lot of regulation at the level of GnRH that has yet to be concretely delineated. You know, we still are learning. I actually think, you know, we're going to start to do what I would say phenotype, genotype correlation to understand like what kind of PCOS a patient has. And just like when Dr. Tarlatzis is showing us subdivisions of low responders and high responders, I mean, we have to get a little bit smarter in thinking about PCOS as more than one homogeneous condition. So cause and effect when you have high AMH may be really different than cause and effect in PCOS when you have low AMH. And I think the phenotype is kind of mushy, right? You have a broad phenotype, and on all the organizations actually leave plenty of room for misdiagnosis, right? Because they say chronic anovulation, and then, you know, evidence of hyperandrogenism, that's like a huge bucket. And then we're trying to think within that bucket, how many subtypes might there relevantly be from a clinician's point of view? Or if you want to do what I like to do and look at the neuroendocrinology of it, you're probably not going to end up with the same neuroendocrine pattern if you don't have the same genes. So 14 genes is 14 factorial. You do the math. That's a lot of heterogeneity coming at us. Sorry, you know, we're just not going to get this into one bucket. That's my point of view. And so then how do we treat someone with very high AMH or someone with ordinary levels of AMH? I think we need to start asking that question. So like all good data, there are more questions than there are answers. And for Dr. Naftulin, I can only address a thimble of the questions that Dr. Naftulin has in rapid fire sent to me. How many hours have we got? I'm going to sign off at that moment. But and the same for the metabolic, right? I mean, they're not all the same metabolically. There are some PCOS women who do not have a metabolic phenotype at all. And so, thinking of metformin for all is not a very good idea in my mind. I think we need criteria.
Thank you. It's an answer and it's a question at the same time. Now to Basil. With a question, is there a place for metformin in fertility treatment of PCOS women? And Zenta Shraf add also, should we continue the metformin even after they become pregnant? Is there any benefit by continuing in pregnancy? If so, how long should we continue?
Thank you. Very relevant questions. Concerning the first one, it depends why are we treating the patient. Now, it is clear from the studies I showed that metformin alone does not enhance significantly the ovulation rate. However, it is associated, and I think there was a question like that from Fred, it is associated with weight loss. Some people are not sure whether it is an effect of metformin per se, or is it because some of the patients have gastrointestinal disturbances, and that's why they lose weight. Now, I have no data concerning visceral fat that specifically Fred was asking. Concerning, so metformin may have a place, but it is not the medication for PCOS as initially people were thinking. I think it has a role definitely in women who have insulin resistance and in women who are obese, of course, and in women who are clomiphene resistant. So in these women, the combination of clomiphene with metformin is associated with better results. Now, concerning pregnancy, again, I think metformin is in class 2, I think, if I recall from the FDA. So it's considered a relatively safe medication during pregnancy. And that's why some people give it also hoping to reduce the incidence of miscarriages, first trimester miscarriages. But I think most of us stop metformin as soon as the pregnancy test becomes positive. So it's a more conservative, let's say, approach to be on the safe side.
Yes. Then now another question coming from Fred Naftulin. He writes that with Angela Palumbo, we are finding a connection of the ovarian renin-angiotensin system to ovarian organelle abnormalities in a murine model of polycystic ovary syndrome. We also found increased ovaries in the ovaries of PCOS women. Has there been other evidence connecting PCOS and the ovaries? The ovarian renin-angiotensin system. This is for, I think, for Sarah.
I saw that question. I mean, it's the role of that kind of feedback, and then now we're talking about mineralocorticoid receptors in the brain, and GnRH regulation hasn't been very explored. It plays a fundamental role. And mineralocorticoid receptors play a fundamental role in regulating cortisol and CRH and ACTH. So could it play a role in PCOS? It could. People have looked at the HPA axis in women with PCOS, and, I'm going to make this very gross overgeneralization, and I apologize in advance, but on average, if they have a classic PCOS-like presentation, they're not hyper-reactive to stressors. And whether that is due to mineralocorticoid receptor activation or, other parameters like testosterone playing a role in any of this, anybody's best guess. And again, another whole area for Dr. Naftalin to keep helping us with, because this is, as my mentor used to say, an ocean amount of information. And I know that Dr. Naftalin will chuckle over that one, but yes, this is such a large amount, a vast ocean of exploration that needs to be done. But yeah, I think it could play a role. Absolutely.
Can I add something, Andrea?
Yes, please, you can go on.
Number one, I'm very happy to see that Fred is in great shape from the questions that he has posed. And actually, I would like to mention that it was Fred's idea that we explored many years back, and we described the renin-angiotensin system in the human ovary for the first time back in the 80s. And here we know that PCOS women are more prone to develop OHSS, and we know that vascular endothelial growth factor plays a key role in this syndrome. So again, it will be exciting. I know that Sharon answered that on a different level. I'm talking about the ovary, that there may be a good interaction there with angiogenic factors, pro-angiogenic factors, that may predispose to the occurrence of OHSS.
And also, we have another question, Basil, for you from Mangalore Damodarkini. What is the role to add for addition of substances like inositols in polycystic ovary?
I think there is now some evidence emerging. I mean, there have been several studies, but I think there's recently a meta-analysis as well, showing that the use may help women, and it helps normalize their menses in several cases, but also it may help the response to stimulation or to ovulation induction. So I think there may be a role there, but we need more data in order to identify whether this is pertinent to all women or subgroups of women, and which subgroups of women. My first guess would be the more obese patients or insulin resistant. But again, we need to find out that in order to be able to develop our strategies, therapeutic strategies.
Thank you. And then I'm sorry, we receive a lot of questions. And then, okay, this is also for Sarah. Do you have any data regarding the effect of GABA on clinical and metabolic parameters in patients with polycystic ovary?
I mean, direct data is limited. However, GABA is a central metabolic regulator. And in one of my slides, I kind of tried to synopsize how these things work. But insulin can access GABA, and glucose can access GABA through the fenestrated vascular wall in the CNS at that level. So the hypothalamus doesn't have a complete blood-brain barrier. And there are actually neurons, perivascular neurons, they're called, where they're like tanocytes. They take up the metabolic signal and feed it to that part of the hypothalamus. And GABA is a regulator of metabolism. And we know this from anti-epileptic drugs, from seizure medications, that you actually get a fundamental effect on metabolism, as well as a, kind of a PCOS-like phenotype when you regulate GABA. We have to be very careful when we regulate GABA when we do studies, because if you lower GABA, actually, you can cause seizures. So it's not the easiest thing in the world to study. We were trying to study it using actually flumazenil and neuroimaging, and we made some limited progress in that direction. But the neuroimaging studies are quite expensive. So we did show, this has actually been shown that women with PCOS who have high insulin levels have kind of a different brain, if you will, and a more depressed brain. So it may be that it's not just one factor. I think that thinking of PCOS as any one factor is wrong. It's the soup. that's playing upon the neurovascular transmission of signaling to GABA that really determines how you get the rest of the cascade to function. And I know people hate this amount of complexity, but I don't think it's irreducible. I don't think you can make it simpler than what we are showing right now, that it is this variety of signaling systems that have access to GABA and then have access via that cascade to GnRH. So should metabolism and reproduction be linked? Of course. This is like fundamental. So, but what should we as clinicians do? I think we need to have things that we check for everyone. And, where I was going earlier in my little advertisement for adding in assessment of metabolism before doing ovulation induction or infertility therapies, I feel strongly about. But I wouldn't want to give metformin to everyone, because if someone came in with a hemoglobin A1C of 4.7%, a BMI of 19, and they had a high AMH, I don't necessarily think that that's a person likely to respond to metformin, may respond to other drugs much more successfully. So I do think we have to be clinical in our approach and be personal in our approach to medicine, including in women with PCOS.
Okay, thank you very much. And then now we have one question. Since ovarian cancer is associated with incessant ovulation, does polycystic ovary protect against ovarian cancer? Who want to answer?
Well, both.
Both. Okay.
Sarah, would you like to start?
Yes.
I mean, can you read that one more time? I just want to make sure I heard it before I
will
launch.
repeat also who is the request is coming from Fred. Since ovarian cancer is associated with incessant ovulation, does polycystic ovary protect against ovarian cancer?
I have seen no studies on that. Doesn't mean it's not a great question, but I have a better question for Dr. Naftalin, if he knows the answer, which is, does having PCOS protect from dementia? Because if high steroids are good for the brain, and there is a lower rate of dementia, all-cause dementia in men, will PCOS women be intermediate? So who wants to do that one? That needs a nice big database and a lot of free time.
Beautiful question. I am also, I will put a question about androgenization of the brain androgenization, and the data that you have mentioned about the gender identity perceived by the individual, and some incidence of greater incidence of lesbianism in the polycystic ovary patients. I would like to give some more, greater comment about this point, because this is also very important. Now we have a greater evidence of the important incidence of the lesbianism is more widely perceived in the general society. And in fact, also in our clinical observation, some of them have the polycystic ovary phenotype. Can you give a comment about that one?
Yeah, first of all, gender, what is traditionally female and what is traditionally male is subject to time, right, and society's interpretations. But when you do this inventory called BEM-sexual inventory, you'll find that what women perceive as appropriate sexuals has really changed in the last 40 years. And what men perceive as appropriate sexuals has not. And everyone's moved toward the masculine. So it's kind of a whole societal thing where the binary didn't seem to be working out for everyone anyway. And then there's gender identity, which is what I'm talking about. And then there's sexual orientation, which is, so some of the slides were on psychological functioning. And that looks like PCOS is a risk factor for, depression and other kinds of what we would call syndromal psychiatric conditions that might actually need treatment and identification in patients. So first we have to ask. And that's, I think, the biggest problem right now is people forget to ask women with PCOS about their psychological functioning. They also forget to ask them about their gender identity and their sexual orientation. And, I think sometimes it's very hard for patients coming in for infertility to actually broach the topic. But if you are an askable physician, you will learn more than if you are not an askable physician. But if you want to advertise that you're an askable physician, you can actually ask a few warm-up questions that are not going to be too polarizing for the patient and indicate willingness to hear. But I think for infertility patients, this is often a big topic for them, and they're just really not sure how to tell us.
Thank you. Okay, and then now we are at the end. I would like to tell you that we have reached more than 320 persons, and still we are nearly 300. And then I would like to have from each one of you a personal conclusion about the topic and about your suggestion to our friend and colleague clinicians, what to transfer in the clinical practice of your observation. This is for you. And for Basil, what is your first clinical approach in the fertility, in the future fertility for the young polycystic adolescents? Then first, Sarah.
So first of all, there's another whole topic we didn't discuss today, and I look forward to talking about it sometime soon, which is pregnancy outcomes in PCOS, related not just to infertility interventions. So I think that was one of the topics we didn't talk, and that's really important for clinicians and also very important for infertility specialists to counsel patients about in advance, right? So, we have to put that on our radar screen. I just made a talk about that recently, and I was kind of impressed the amount of information out there. And then I have to say that my title is incorrect because it's not the brain phenotype, it's the brain phenotypes, because really the point of my talk is that PCOS is heterogeneous, both at the level of the brain and at every other level as well.
Thank you very much. Now, Basil.
Okay, so I think that as our knowledge expands, I think I would stress that we should always counsel our patients to lifestyle interventions before embarking. We should do that even if they are not going to get treatment and try to get pregnant on their own. And I think with the knowledge that we now gain concerning epigenetics and the influence of obesity and insulin resistance on the fetus and also future child's life, I think we should be very persistent on that. Although many women, I guess especially in the Mediterranean countries, Andrea, they when they hear that, they say, yes, I know, but how can we, when do we get some drugs now? So, although it's important, we should keep trying to convince that healthy lifestyle is important to prepare yourself to have a good pregnancy. The second thing is that I'm a bit worried about the letrozole. I'm worried that it is an off-label use because it's a good drug and apparently very effective. And so we should probably try to convince the company to change that, because it's a pity women to not have the opportunity to use that drug, which clearly is more efficacious. Number 3, ovulation induction, I think based on Roy Homburg's study and others, I think that could be a first-line option, provided that we are cautious, conservative, and cost is not an issue, and the patient is available for proper monitoring. And finally, I think IVF. I don't think that laparoscopic ovarian drilling should be part of our routine, only incidentally, and again for experienced endoscopists and not very aggressive ones. IVF is a viable option. It's expensive though, but I think somebody should do a cost effectiveness analysis, because we get quite a lot of oocytes. We get beautiful embryos, several of them if the patient is young and all these things. And then you can have, as many kids as you want, but one at a time. So with single embryo transfer, we can control that. And number two, we have practically eliminated OHSS.
Yes,
all of us remember the early days and the agony when patients were admitted in the hospital with belly like this, and then punctures and punctures and punctures, and now we don't see an OHSS. So all these things, I think, have made the picture quite different and safer for women, which is what we are all.
Medicine ameliorate. We were cause of some disaster, but they were disaster needed to better understand how to manage and how to go.
I remember, I think in one of the very early lectures, it was mentioned how I killed a woman. And it was practically from OHSS. And it was the era when, the early colleagues didn't know about OHSS and how to control it and how to avoid it. So you learn by experience. That's, how things are.
Something important. And okay, dear friends, I would like first of all to thank you for your, for being with us today, for having given your time to ISGE and to this beautiful webinar. We had a good number, a fantastic group of attendees. We are very happy about that one. And I would like to remind you that we have next webinar will be on the progestogen in menstrual cycle related pain disorders with Professor Charles Sultan and Professor Stefano Luisi. This will be April 21 at 3 o'clock Central European Time. And also, I would like to invite you to join us in Firenze for the 20th World Congress of Gynecological Endocrinology from the 11th or 14th of May, next May 2022. The Congress will be available. It will be on site, but it will be also available online. Those who cannot come to Florence, I suggest you can register for online and follow our Congress. It will be fantastic. The Congress will also remain 6 months on the web. And then we have, I remind you that we have ongoing from the International School of Gynecologic and Reproductive Endocrinology, the menstrual cycle disorder course from etiopathogenesis to diagnostic and treatment, which is an online course already started 19th of January, who will end 7th of July. Every 2 weeks, we have a webinar. There are 13 webinars. All are still already recorded. And then you can, those who can register now, they can go to see what the courses already done until now. Then I thank all of you for your presence, and I wish to all of you a good time and enjoyment. We hope all peace for Ukraine, and we invite all of you to come to our next event. Thank you very much for your presence. Thank you, Basil. Thank you, Sarah, for your availability and always for your presence with us and your support in the ISGE activities. Thank you. It was fantastic. We will see each other in Firenze, and I invite all the others to follow our webinar. Thank you very much.